Over this morning from Children's this rainy morning to give us a talk about pediatric chronic rhinosinusitis. As you know, in the last couple of years, Greg Davis has given us the adult version of this, so this was long overdue to have the pediatric input. So we'll give it over to you. Thanks for coming.
Thank you. It's a great privilege to be here. You know, and by way of introduction, we were just talking. I've been here since 1995 at Children's, and you know, lots of interaction with Northwest Allergy and asthma over the years, certainly, and lots of back and forth. And you know better this than I do, but when residents rotate from primary care in our service, which is less and less, but we really miss them, and we encourage, if you ever have the chance. You know, I always say, well, as I recall, in 1980, the U.S. government standardized health, whatever it's called, 15% of adults were skin prick test positive to something real, and then, but it's increased, and then by 1995 or something, it was like 30%. But if you look in a tertiary care Oto clinic, like where you got to run the gauntlet of going through the surgical center and waiting for 6 months and fungus and everything else, it's way higher than that. So we're gonna, one theme is that a lot, not just rhinosinusitis that we're gonna focus on today, but otitis media and big adenoids and on and on and on and on and on. Allergy is in the background. This is just a picture. Look at it. This will be a theme. Like one theme is, you know, how do you define chronic rhinosinusitis, and nobody has the answer to that. But if somebody comes in with headache as the primary symptom, like this guy who showed me this picture, wearing all black and self-acupuncturing for his atypical facial pain, but that must hurt too, and headache, you can bet he will have normal imaging, right? But which he did. So we'll get back to that. This is a little dated, and I will give you the update. In terms of evidence-based medicine overview, my European friends, like Valerie Lund, get together periodically for the European position paper on rhinosinusitis, which is a free download, but it's like 150 pages if you download it. It got updated in 2014, and they are working now to do the next update. But I don't think a whole lot, other than getting into, you know, the monoclonal antibodies for interleukin 4 and 13 and whatever. There's not a whole lot of new stuff that's going to be coming out, I think. But so the EPOS 2014 is if you want something that's kind of goes through systematically evidence-based medicine of every therapy and stuff like that, that's a good resource. So yeah, quiz question we were discussing. So if you look at incidence of ICD-9 coding for pediatrics, you know, it's right in the smack dab in the allergy spectrum, because, you know, nasal congestion, runny noses, food allergies, and then when you get into all the stuff that allergies in the background of, like I just mentioned, otitis media, big adenoids, acid reflux, atopic dermatitis and eczema, asthma, on and on and on and on, right? And the whole world seems to be shifting to Th2. That will be one of our themes. Here's the allergic salute. By the way, which I didn't throw in a lot of this, but here's a couple. Maybe you already know this, but in terms of physical diagnosis of kids, that's fun to do. That's the allergic salute, obviously, the crease, you know, above the nostrils for the kids that do that all the time. Things that you may not know about: long, silky eyelashes, so that, you know, if your meibomian glands to your lashes are reacting to stuff in the air, you have more blood flow and you will get long, silky eyelashes. So if you attend a lecture on pediatric allergy here in physical diagnosis, you'll talk about allergic shiners, because the thin eyelid skin will show the venous blush. But if you go to other countries in Europe or Mexico or South America, it will talk about pestañas brillantes y largas, long silky eyelashes, as a physical sign. Another physical sign in kids, this is fun to look for, is a long, pale uvula. The uvula, so remember, the roof of your mouth is the floor of your nose. and our uvula is designed like the wingtip on a 787 to suck in laminar airflow for better aerodynamics. So it'll get a more concentrated whatever, dust mite or pollen exposure. So you'll look at the kid that has the pestañas brillantes y largas and the salute, and they have the long tail uvula. And then you'll say, you look at the parents and you go, hey mom, does the roof of your mouth ever itch and drive you crazy and you want to stick your finger in there and scratch it? And she goes, yes, you're a genius. So the kids don't, that's a theme. Like the kids, like a lot of times the parents will say, my kid doesn't have allergy because they don't itch and sneeze and stuff like I do, but you know, often that comes a little bit later.
Are there societies where those long silky eyelids are a prized possession?
Well, I don't know. I mean, it's not bad, right? It's not bad to have, for sure. But, so yeah, there is no real definition of chronic rhinosinusitis. Actually, the FDA won't really touch that for drug studies because it's so nebulous. But the point is that when you talk about symptoms of congestion rhinorrhea that go on and on and on, that's probably more allergy, but sinusitis might be, I'm fine, then I catch a cold, then I really get sick where I'm sneezing out green snot, and then I get better, but it cycles. That might be more correlating to imaging findings. So yeah, we're going to go through, so in my clinic every day, we overcome a lot of common misconceptions. So one might be, you have a child of allergic parents who's, let's say, 5 years old, they have symptoms, somebody puts them on Flonase, their symptoms get better, they get referred for allergy testing, it's negative, the doctor tells them to stop the Flonase, and the symptoms come back because they're not allergic. So that's something we run into every day. So like how sensitive is skin testing and at what age, we'll get into that. And then the corollary is, if you're negative at age 5, does that mean you're going to be always negative? Like how stable is that over time? The answer is not stable at all. The older you get, the more stuff shows up. It used to be taught that allergy is not associated with chronic rhinosinusitis in children. I think that's because if you take super young kids where skin prick test is often negative, it's hard to show an association with sinusitis symptoms. And then there were studies in the past that said it doesn't help to do saline irrigations, but now we think it does help. And we don't know about sublingual immunotherapy yet. Another thing too, in terms of pathophysiology, we used, especially back in the 80s, we thought that, well, everything was bacteria and your sinuses are supposed to be sterile and you just have to match the right antibiotic to the person for long enough, and people would get antibiotics forever and ever and ever. Turns out that was bad because it changes your biome and shifts you even more into Th2, especially under age 3 if you get antibiotics. By the way, in Europe, it's a black box warning, antibiotics under age 3. If your kid has an ear infection in Europe and somebody wants to give them antibiotics, you have to sit down with your doctor and have a black box warning discussion. Isn't that interesting? Yeah, because well, that's in Northern Europe. Because there's no question that's going to push you into asthma, atopic dermatitis, et cetera, et cetera, et cetera, right? And of course, it becomes, unfortunately, it's a herd thing. Like at this point, it probably doesn't matter what you do to an individual child because the biodiversity is now so low in our population in general that the damage is done. Anyway. But that was a slight digression. But that's part of this whole thing. So yeah, we must now account for inflammatory and immunologic dysregulation, and we'll get into the superantigen theory about why certain bacteria cause more trouble in the allergic diathesis person, and some strategies we can deal with that. So themes and trends. A lot of people that come to our office with sinusitis have crystal clear sinuses on imaging, the gold standard definition of sinusitis. They don't have it, especially if they have a headache as their primary symptom. We're seeing more and more Th2 shift. We're seeing more and more a migraine because that's in that spectrum. When I came to Children's in 1995, there was nobody, like if we had somebody we thought had atypical facial pain or migraine, nobody in neurology would see them. Now I think there's 7 or 8 people that just kind of do that all day long. So it's an amazing change. And like we kind of touched on, if somebody, we'll get into this, is going to be, I'm going to pound on this theme. If somebody says, my primary symptoms are migraine and atypical facial pain, those are the #1 problems, their CT sinus imaging is more likely to be crystal clear than a random person pulled off the street. By far, there is an inverse correlation. So that's a take-home theme for today.
Is it a board?
Yeah. Oh, yeah. So for kids, so when you're talking about the spectrum of chronic rhinosinusitis symptoms, obviously we're thinking about allergic rhinitis, the theme of the day, tendency. And again, often we have to kind of go on history, which we'll get into because skin testing might be negative in a young kid. Viral illness is usually the trigger, of course. And when things don't really, and adenoiditis and so forth, and when things don't add up, we start to think about looking for primary ciliary dysmotility or cystic fibrosis and so forth. But I put anatomic obstruction last, right? And surgery changes anatomy. I mean, there's, like, when you're talking about big adenoids, that's low-hanging fruit for us to make people better. That's not really what I'm talking about there, but, kids, compared to adults, are much less likely to have polyps or some physical anatomic obstruction that you can just make them better. What causes you know all this better than I do, but the hygiene hypothesis, what causes the Th1 to Th2 shift? The short answer is modern living, right? Urbanization, small families, vaccinations, high-fat diet, early introduction of food antigens, maybe early viruses like RSV, other chemical exposures, the things we do to change our biome, like eliminating H. pylori, gastric ulcer disease. Interestingly, a lot of environmental things like triclosan in soap, the so-called antibacterial soap, is bad. And again, we've already mentioned, but maybe we should put at the top of the list antibiotics under age 3. But again, at this point, as a society, maybe it doesn't matter because our societal biome has become so sparse that maybe it doesn't matter. You can correct me if I'm wrong. The gold standard for defining allergy is history of symptoms related to specific antigens and RAST, or skin testing demonstrating specific IgE hypersensitivity. Is that still true, more or less? Okay. But the problem with young children is that allergy testing is insensitive and history is vague. Symptoms are nonspecific and overlap with viral illness. So we have to kind of get into the whole picture, which we'll talk about of their allergy stuff plus their family history, right?
One thing that's wrong is we don't actually call it RAST anymore.
Yeah.
It's
Okay.
changed the technology.
Okay.
Yeah.
I will fix that. So there is this thing, you can update me on this too. Localized allergy, that means their tests are negative, but if you biopsy them, you see IgEs and stuff like that, and they look, this is supposed to be a left inferior turbinate, which is swollen. And swollen might be defined as, like if the septum is over on that side and the turbinate is that big thing, it might be defined as you get less than 3 or 4 millimeters between septum and turbinate. Maybe that's 1 to 2 millimeter, I don't know. And then you can also see sort of laterally a little clear runny nose. In reality, that would look kind of lavender. This is bad color reproduction. And that's venous blood flow, right? Just like allergic shiners. But that's what allergy looks like. And that's not a polyp. We get tons and tons of referrals from primary care for allergic kids that look like that for polyps. But we'll show you at the very end, a polyp looks more translucent, pale gray, and it's going to be a little bit higher up. If you think of a line from nostril towards the medial canthus, halfway up there is the middle meatus where the sinuses drain in, and that's usually where polyps form, and it might look like a pale, fleshy, translucent thing that doesn't look like dense pink or lavender opaque mucosa. So that's one thing. All right.
Question
Yes.
about, so that's always been a controversial topic if this exists. If we see skin test negative people who have IgE locally only, if such a condition, at least in adults, exists, or call it non-allergic eosinophilic rhinitis.
Right.
How do you think about this in kids?
So what I think about in kids is most of those kids, we're going to get into that, most of those kids are going to evolve into test positive. It's just that maybe they don't have enough immune maturation to show up yet. So I think they're, and if you, and it's interesting to me, doing this for a million years, like let's say you have the 3-year-old that seems kind of allergic and then their test is negative, but their parents have allergies, and then you see them, like I might do, 20 years later or 15 years later, and they go like, oh yeah, he's positive to everything and we're doing everything. And you go like, well, is he, this, to you, the parents, does Billy seem different in terms of his rhinonasal symptoms now versus at age 3? And you're like, oh no, he was born that way, just like me. That's the story you get, right? It's just that the testing doesn't show up until later a lot of time. I think it's one theme of this, right? But that's often the story that we'll get. A little bit about, what is this the right terminology still? This is the thing that's always, the terminology is changing. Or is it the, whatever, what used to be called aspirin exact, but now it's like non-steroidal.
I think this was.
Is this still good? Okay. And we actually do run into this in kids, especially anybody that has bilateral polyps. We're going to think of this for sure. Not every day, but anyway, but it's something to keep in mind too, that up to 20% of steroid-dependent asthmatics without polyps still might have it, but certainly we think about it when we see bilateral polyps, usually in teenagers with allergic parents. And that's another place where obviously you're going to see tissue eosinophilia. And we'll use Dr. Verant to help us figure this out normally, and that's what we do there. But so what's new there? You can update me. Like, does anybody, like, is there anything new in aspirin desensitization, or like where, in terms of who we should refer from Oto Clinic? Like, let's say they don't have polyps, but they never get better, and I don't know.
Drew and Matt should be here, but what I think it might be new is we may replace the complexity of aspirin desensitization with biologics.
Yeah.
That'd be the new thing
I think it
too.
would work better.
If a pediatric indication down the road for dupilumab here.
Yeah, right. This is a little bit more about eosinophilia. This is actually a study I did a while ago about something that we don't see around here very often, allergic fungal sinusitis, much more common, or used to be on the 35th parallel or 30th parallel latitude. That was immunohistochemical stain for major basic protein in these people that get this massive stuff. However, again, back to like the allergy, how you define allergy and how does it fit into chronic rhinosinusitis in pediatrics. My friend Kenny Chan in Denver found that kind of like adults, they tend to have increased basement membrane thickening and eosinophilic infiltrate compared with controls. Like a control might be someone having ear tubes with no rhinosinus symptoms or something like that. So you see that Th2 in the background more of people with chronic rhinosinusitis symptoms, even in the pediatric group, but maybe not as much as you do in adults. Maybe that's, they haven't have enough time for the inflammation. So this is, again, this is my perspective because I have sinusitis clinic. So people are coming in with a diagnosis of sinusitis. So when, like if I'm sitting in the team room and the resident's going to go see the new patient, I will say, ask them about all this other stuff to help, because again, like to figure out who's, plus obviously family history. And so ask about allergic rhinitis, recurrent croup, GERD, eczema, et cetera, migraine. And they'll come back and inevitably they'll say like, no, there's none of that other stuff. And I'll go like, really? And so, like I am Dr. House. So then I walk in and I go, anybody in the family have migraine? No. Nobody in the family has to go into their bedroom for 1 to 2 days, close the door, not eat, and not talk to anybody. Oh yeah, Aunt Edna does that every 3 weeks, right? So then I'll go like, has Billy ever had eczema? No. What is that horrible flaking red rash all over his cheeks? Thank you, doctor. I've asked my pediatrician many times what that is, and I know. So then it's on and on. Did Jennifer have reflux as a baby? No. Did Jennifer ever take that medicine that's now banned for being a carcinogen called ranitidine? Yes, yes. Oh my God. Before that, she never slept and I mean, so like, you know, if you dig a little bit, this is like all day long sinusitis clinic in our clinic. This is everybody is like this, by the way. So, you know, again, in the 80s, it was all, well, it was bacteria, but you just didn't, you know, you didn't give them the proper 16 to 32 weeks of triple coverage, broad spectrum antibiotic, right? But now it's different. Instead of being primary infection, it's probably primary inflammation tendency, sometimes aggravated by infection, certainly viral triggered in kids. And it may be that children with chronic rhinosinusitis are more allergic than adults. It's hard to test them. And we see the shift to Th2 profile and the treatment philosophy shifting away from antibiotics to a more balanced regimen, including anti-inflammatory agents. And again, we talked about this before, but it's deficiencies of mucosal defense, not anatomic obstruction. Like I tell parents, I go like, did Emily have rhinosinusitis? Oh, they'll come in and they'll say like, my doctor said Emily needs sinus surgery because her openings are too small. They're like, really? Let's examine that line of logic. Did Emily have these symptoms under age 18 months? No. It was when she went to daycare, and it goes, yeah, it's when your immunity wore off and she started having viral illness. So, like, she was born with teensy tiny little openings, but she was fine. But now she's been around, she's got sensitized to the environment. She's at that whatever age, but still often the kids, you know, it takes kids up until age 12 or 14, you're the immunologist, right, to get to adult full immunology. In terms of viral illnesses, age 7 to 8 seems to be the inflection point where they often start to kick out a lot more. And we are very loath to consider surgery under that age, just while we wait for nature to mature their immunity, right? And while I'm on that topic, in case I forget at the end, because I can't remember how much we went into surgery on this one, but yeah, surgery makes holes bigger, but that's probably not why it seems helpful in the properly selected person. It may be more the target theory. So for example, this is not my theory, but if you take 8 to 15 ethmoid spaces and you coalesce that into one space, I forget the math, but you maybe have reduced the surface area of mucous membrane there by 100-fold. So if your problem is that your mucous membrane reacts to the environment, you just drastically decrease the target of inflammation. So it may be more that than the holes got bigger, right? Or as I joke with my residents, yeah, we're going to go in there and make those sinus holes more better. George Bush 43, right? But they were probably evolved to be pretty good to begin with, right? That wasn't the problem. I mean, it might be if they had polyps or something like that, but, and by the way, you know, if you look at having, like I was, accident of history, I got my hands on the first set of endoscopic sinus surgeries ever to come to the United States in 1982. So I've been doing this a long time. Then there was that explosion of, you know, everybody needs it. And now, you know, Greg Davis and, you know, very smart people. And, you know, I think hopefully it's found its level of who it helps more. And maybe, I don't know, but a small fraction of the incidents, not a small fraction, but a fraction of what it used to be done, hopefully through better thinking. This is just another part of the reason why modern living maybe gives us trouble, but it's just the price we pay. So with Prevnar, we knocked out, you know, pneumococcus, which is like the big bad wolf in the woods. And that was good because, you know, from our point of view, we don't have the hearing loss and death from meningitis and the deaths from pneumonia and so forth. But it's bad because the big bad wolf was the only good competitor for the other big bad wolf, which is Staph aureus. So we have now competitive inhibition, loss of that, and now we have more staph. And the problem with staph is that it is a super antigen in the Th2 person. So that's probably part of what we're seeing sometimes as a new problem. This is just, if you wonder about nighttime cough, I thought this was a sinus patient that we had a couple years ago that I took the picture. So going sort of, it's like we're going to go from front to back. The forehand picture in the right-hand upper corner is the middle turbinate on the left side, above the inferior turbinate septum over there, and some pus coming out behind the uncinate. But then as we follow it back, the cilia propel it back into the nasopharynx and then down to the oropharynx. And so that accounts for the fact that, especially nighttime cough is a symptom of anybody's sinusitis, but especially in kids. So that's a good history to ask for. And I tell the parents that, it's like your maxillary sinuses are like buckets, and they lay back and the buckets empty out and then they start coughing. That's a visual. This is a view, if we're looking like upside down through a mirror at the nasopharynx, and that little red rubber catheter is on the palate, so that's actually in reality inferior, but this is what it looks like when we're looking at it. And those big giant blue things are inferior turbinates that are sticking out of the nasal cavity into the choanal opening. And I forgot, I should have put, by the way, this is something you can see.
There should be a pointer there.
Use your finger.
Oh, I can use, what now?
Just a mouse.
Yeah.
The mouse. Where's the mouse?
It's on
It's on
the
the
trackpad.
The trackpad.
It's the trackpad, right?
Ah, got it. Okay. Thank you. Okay, Boomer. So these are the big inferior turbinates, and here's the septum. Here's superior, inferior. But I forgot to bring a picture in, but if you have a lateral X-ray or the scalp view of a CT scan of the head, and you look lateral, the radiologist will never call this, but you can see this very easily once you, I forgot to put a picture of it, but you can find the end of the septum, which is bony, so that's going to be like a line. Then if you see this horizontal gray shadow of the turbinates projecting past that into the nasopharynx like this, that's big old turbinates. And if they say congestion, congestion, congestion is my main symptoms, and they've been on Flonase and not better, that from our, the number one adult ear, nose, and throat procedure in the United States that's reimbursed, because the number one by far is Botoxing, but that's reimbursed is turbinate reduction. And I mean, the people love you for that, right? They're like, thank you, I can breathe and I can get my Flonase in there and so forth. So that would be obviously a case of turbinate reduction.
Scott, is that bony turbinate reduction, or is that tissue that's inflamed turbinate?
So there's a million ways to do it, and it depends on the deal. In kids, we're more conservative. I don't take out usually bone much at all. I just usually trim off the bottom inferior medial 20% until I can see the choanal openings, and it takes 10 minutes the way we do it under a brief day surgery, and we don't put packing in or anything, and they usually go to school the next day. It seems like it would hurt, but it doesn't. So yeah, it just depends on the deal. I don't do adults. In adults, I think they get more chronic osteitis and more bone needing resected, but in kids, they're simpler. It's almost all this hypertrophic mucosa. This is like an older teenager. They might need some more, yeah.
So if you biopsy that, it's not eosinophils, it's not
It is.
inflammatory. It is.
Oh yeah, all the time, for sure. Yeah. I did something wrong here now.
So you're supporting that in those who need it, turbinate reduction is a valid and useful procedure?
I do.
Yeah.
So let's talk. I didn't get into that. I didn't get into too much about treatment, but if like the classic would be, we're going to get into diagnosis in a minute, but a teenager comes in and they have documented or clinical allergic rhinitis, and you have to actually document this part in the record. They have given a good try for nose sprays, including topical steroids. They're not happy, and they have big turbinates. we will offer it and we'll say, in terms of, if we get to it, I have a case that I just saw last week of this exact thing, but we'll talk about it now. We'll say, like, I'll give you 100% money back written guarantee. We can make you breathe better through your nose. That's important to you. And the other thing, again, is, and it also reduces a lot of postnasal drip symptoms because we get rid of a lot of the surface area that's making mucus. So if that is a big bother, it'll help that every time. And then also, you know, if you stick with it and do your nose sprays, they'll work better for you because they get into your nose better. So I mean, in terms of it takes 10 minutes and how happy people are after, it's pretty good, but it's really good. But if they have headache, that's a whole different story. But the last case I'm going to show is kind of an interesting mixture of that. All right, so kind of turning the cycle. What is chronic rhinosinusitis? Persistent symptoms greater than 6 weeks? No. Persistent symptoms, nasal congestion all the time. That's not sinusitis. You don't breathe through your sinuses. You might have sinusitis in addition, but in a kid, you're going to have big adenoids or big turbinates. And again, we can figure that out with a scope or a lateral x-ray very quickly, plus exam. Do you have daily headaches all the time? Not sinusitis. I mean, there's rare exception. If a 13-year-old male that never had symptoms gets a bad cold and then goes diving off the high diving board and has an excruciating frontal headache, that's an emergency. You need to make sure that he's not getting an epidural abscess. But I'm talking about the otherwise normal person that's like headache, that's going to be not sinusitis. So yeah, again, sinusitis is, I'm better and I'm fine, but then all of a sudden I catch a cold and I get my symptoms, nighttime cough, low energy, facial pressure, but not sharp stabbing atypical facial pain, and that's likely to correlate with image findings. So again, it's not really so much infection aggravated by underlying inflammation now thinking, but rather the reverse, most commonly. Cultures show staph aureus and coag negative staph, but it's often the cultures are similar to controls. But again, getting to that point, the difference is that the chronic rhinosinusitis patients in the background have more inflammation, often neutrophils and eosinophils. And if you treat them long-term with broad-spectrum antibiotics, which we are doing less and less, I must admit, you will often get gram-negatives. We don't get that so often in kids like I know Greg Davis fights that problem all the time in adults, like the adults that have been through just massive antibiotics and now are colonized with gram-negatives and a bigger problem for them, but we don't have that, luckily. And the other thing that's really good is, again, having the perspective of doing this forever, there was a time when everybody got CT imaged all the time. Like, I remember once I was on a panel at a meeting and somebody presented, you know, CT after CT after CT after CT on this patient, you know, and it was, you know, and they finally said, they said, well, Dr. Manning, what do you think? And I said, well, I think radiation therapy is not working. But luckily, in large part because, you know, reimbursement has dropped. But, you know, like, this is off the record. You know, like at our hospital, they claim they don't, but they definitely keep track of, you know, how much you contribute to the profit centers, and that determines your parking place, right? And so that's why the neurosurgeons get MRs on every patient before and after. But now, and it used to be like I had a better parking place because we got CTs, but now I'm parking in the not covered garage, like behind the Brett Boone trailer, which is where it's also where they keep the horticultural people dump the weeds. And that's because CT scans lose money now. But that's a good thing, I think, because, you know, the incidence of radiating everybody has drastically dropped, which is a really good thing, in my opinion. All right, so that's the same old theme, that it's inflammation in the background. So here's a little super antigen theory. So this is a left nasal cavity where here's the septum, here's the middle turbinate smashed over to the septum because there's this polypine mass effect. It has these yellow balls in there, which I call wasabi balls. And if you biopsy them individually, they're full of Staph aureus, often MRSA. So we never saw that before. Like, I've been doing this for 40 years. And, but I think that's the allergic person now. I think, again, pneumococcal vaccine, Staph aureus, Th2 shift, and now we get these super antigen inflamed foci that create localized polyposis. Like, so I just threw that in because, you know, I'm like, wow, I never saw that before, but now in the last 10 years, we see that. Like, and I think that's just a consequence of how things have evolved there. So the reason I bring up super antigen is, those of you and maybe in Northwest Asthma and Allergy know that we do love squirting mupirocin in people's noses. The way, I forgot to put a slide of that, but the way we do that is, generally speaking, we just have them take anything of saline that you can pop the top off, Kroger brand saline at QFC or Ocean or AYR. It doesn't matter if it's a 45 or 60 milliliter bottle for this. It doesn't matter. Then we get the mupirocin. So we can have children's pharmacy do this. It takes them 8 hours. Or we can have the parents do it in 1 minute. And because I do it all the time, so I tell them exactly what I do. You have the thing, you pop the nozzle off temporarily. I take the mupirocin, I put approximately like it's a 22-gram ointment or cream, it doesn't matter. Put about 1/5 of it in there. It's super gooey. I use a Q-tip to shove it in, pop the nozzle back on, take a Sharpie and write mupirocin on it. We don't refrigerate it, you're good to go. So that's the recipe. But the logic is, if you knock out the staph, at least when you're having symptom flare-up, then you knocked out a super antigen. Or in other words, the staph, so a common story would be, let's say you have an 8-year-old with, for us, Down syndrome. They have chronic rhinosinusitis a lot. So let's say you have an 8-year-old, snot pouring out of their nose all winter long, every year. You culture it, heavy growth, non-typable H flu, a gram negative, not sensitive to mupirocin, some staph. You put them on mupirocin, parents send me a chocolate cake. True story. Because it's a miracle. They're like, yeah, because the staph was the super antigen that just caused more inflammation. So you knock that out, that's how they do better. And we haven't seen, we just tell them to use it when they're symptomatic, but we haven't seen resistance in the US too much to mupirocin, thank goodness, and there's no absorption. So, but I think for those patients that it's worth a try. And this is the logic of why we do that a lot. This is and where did that come from? That came from dermatology, right? So
I just had a question. So do you do it always with the nasal spray, or is that the same as like just doing mupirocin in the nose when you do like staph eradication?
So you can do either way. If you like a 2-year-old and parents like, I'm not squirting that in their nose, we'll just say, okay, glob it in there, but try to get it in there like an inch to really get on the cilia. But I think it's better if you spray it in there. So we just tell them shake it up in a couple squirts a couple times a day when they're symptomatic. But you can do either way. So this didn't show up well, but this was a chronic rhinosinusitis patient with eczema who had habitual hand, nose rubbing, and then you could see on their hands, that's the only place where they have eczema flare-up. So the idea of the mupirocin actually came from dermatology, that if you have that kind of thing and you put mupirocin, or around their mid-face, then it often cools down. It's the super antigen theory. Just a word, we have to say something about biofilm, but this probably does explain some of the reason why oral antibiotics don't knock out sinusitis as much as we would think, even in the really image-positive people. And it also might explain some of the lack of interesting organisms on culture. So it is, a lot of research comes from cystic fibrosis, and you will see more and more therapies aimed at the biofilm rather than directly bacterial, static, or cidal, right? We've already talked about this a lot, but I think this is the really big news that hopefully which is really happening. Like if the amount of antibiotics in the United States we use for otitis media has drastically plummeted, which is a really good thing. Some of that is the success of pneumococcal vaccines, certainly, but some of it is better awareness of the problems where oral antibiotics shift your biome to Th2. And, you know, it's interesting, we used to always think sinuses were sterile. Nothing is sterile. Everything has its own individual biome. There's more and more data, but it's often conflicting, hard to use right now about what's supposed to be a normal nasal and sinus biome. And it's interesting, even in the nose, like the anterior nose, posterior nose, sinus, adenoid, all have different biomes. But that's a new frontier for better therapy. All right, we got some time still. So we're going to go into some studies just to kind of talk about the things we already talked about in general. So this is from Boston Children's, my friend Michael Cunningham of Boston Children's. And getting back to some of those original questions we asked at the beginning. So yeah, it turns out that if you try to, the best you can, define chronic rhinosinusitis in kids, a lot of them have allergies, and dust mite is the most common, and allergic rhinitis associates with asthma, but not cystic fibrosis, and symptoms overlap. No kidding. Here's another one where chronic rhinosinusitis and allergy in kids do co-associate. And the kids with chronic rhinosinusitis without allergy were more postnasal drip and congestion and cough, and with allergy, congestion, postnasal drip, and itchy eyes. But again, I think what that tells me is the older the kid, the more likely the skin test is positive, the more likely they are to itch. What age is allergy testing useful? Obviously, any age, as long as you realize that negative testing at a young age does not rule out allergy, correct? So in asthmatic kids under age 2, skin prick testing usually not positive. But as they get older, it becomes more positive in the cohort of kids born to asthmatic parents. You probably are more familiar with some of these studies than I am, but I think this is the one from Ohio State Columbus. 200 healthy newborns fall for 20 years, and they are children of asthmatic parents that agree to enroll. And the older they get, the more positive their skin testing is for allergy. And they often gain aero allergens on testing. And so that's a common, like for me, a common story might be, let's say it's an 8-year-old with severe chronic rhinosinusitis symptoms, and the parents go like, oh yeah, Jennifer was tested, but she's only allergic to dust mite. I go like, when is she the most symptomatic? Oh my God, in spring, late spring. And I go like, what about you or dad? Oh yeah, we're the same. We have horrible grass allergy. I go like, well, it's likely that your child will also have grass allergy and it'll show up a little bit later. But that's a common thing too. So yeah, their conclusion was negative testing does not exclude the possibility that they really have allergy, and they might benefit from treatment, but not necessarily immunotherapy. What's the average age that children get immunotherapy that if it's appropriate?
The pediatricians speak up.
Yeah.
I don't know. I don't do
Well,
kids.
I don't. I mean, the youngest I probably do is like between 8 and 10. They have to be psychologically ready for
Correct.
it, because I'm not going to have them coming in off the elevator screaming and fighting their mom. So,
Correct.
there are some kids that are totally fine with shots, and some parents will put them on like when they're 6 or 7. Like the parents are more pushy than I am.
But a lot of it too is that you don't have as many candidates, right, at an
Correct.
early age, correct, by testing, right?
Right.
So in this study, they tested kids at age 5, 11, and
Uh-huh.
20.
Yeah.
And what are the actual numbers? What
Yeah,
percent were positive at each of those time points?
Right, and I can't remember exactly, but it was like, it's like 4, 20, and 85% or something. It was really dramatic, right, like that. And so, we all become our parents was the theme, but you're not. Yeah, so I went to a high school reunion recently, and I forgot I said this, but my friends later emailed me back. They thought it was pretty good. And I looked around and I instantly, spontaneously, I said, who invited our grandparents, right? And yeah, my other line for that meeting was, we were all staring mortality in the Facebook, because that's how we communicate. Yeah, that's the way it goes. Are saline irrigations useful in children? Yes. And the mupirocin, there's actually my good buddy in Adelaide, Australia, who was the person that trained Greg, also Davis, and PJ Wormold, has done more and more mupirocin studies that are very positive too. But one of it, so it really does reduce staph. And PJ Wormold does more quality of life symptom studies where it's helpful. But again, it's helpful in, specifically the allergic type person that has some staph on culture. That's the caveat.
How does mupirocin work? Is it antimicrobial?
Yeah, so it's really strong antimicrobial against gram-positives. So it's that's why they use it for staph carrier state in hospitals. Like if there's an outbreak in ICU and they culture the nurses' noses, they'll put them on some kind of mupirocin. Use those little bullets that you squirt up your nose.
I was just curious, the mechanism that resistance isn't developing.
Is there a microbiologist in the room? I don't know. I mean, Google that. And then the sublingual immunotherapy. What's the latest on that for kids?
Insurance doesn't cover.
Well, I mean, does it work? Is it useful? Should we forget about it?
Good. Nah. I don't know what age it's approved down to.
I think 5 or 6.
5 or 6
Yeah,
for.
5.
I think some of the grass tablets are.
Yeah, Grass Tech is like 5, and the other one is Oralair is like 10.
Does anybody think?
Doctors are
So,
like teen, I think.
Yeah.
does anybody have any
Well,
strong feelings that it can be useful or not, or I don't know? Okay, to be determined. So coming back around. So my resident, I go, when you walk into that patient room, the word sinusitis is banned. So you're just it's gonna be symptom based. Like you walk in, you go like, what's wrong? And they go, sinusitis. And they've heard it from a million people, their primary care and everybody, and to them it means something very specific, but to us it means nothing, right? Because we don't know what it means to them. So if you focus on the symptom, so I literally go, I go like, what do you wish was better, either to the parents or the patient, depending on their age? Tell me the most important thing first, and then you can add in as many things as you want. And if it's headache, they have a clear x-ray. And if it's congestion, we're going to help you, because the domain of nasal congestion is very responsive to treatment in outcome studies. And, the logic is always try the easier thing first. We're going to try Flonase, and then, like we said, adenoidectomy, turbinate reduction maybe, depends on the deal. But the headache, facial pain is very unresponsive to treatment. And we're going to definitely try to reduce nasal symptoms as a trigger, see how that goes, and then refer to neurology as appropriate. The goals of treatment, one thing too is, like if the kids that really do have recurrent or adults sinusitis, it takes a while for mucosal recovery, and if we can, using anti-inflammatories, help prolong the interval between infection, allow for mucosal recovery, that's what we're trying to do. And this is just a picture of an angiofibroma, another nasopharyngeal view, just to show you that not everything is allergy. So that's what we're trying to do. And a lot of times in kids, we're trying to do better while nature helps us by maturing immune function. And again, there's a spectrum of treatment. We will definitely put everybody on nasal saline. And obviously, almost everybody that we see has already been on antihistamines, often Singulair. We're trying to get away from antibiotics, saline plus topical steroids. Everybody Then again, we're going to look in our world, do they have obstruction, adenoids, and turbinates? And we didn't really get into who needs sinus surgery, but it's more, they got older, nothing worked, and they have imaging, consistent findings, and that's who we might think about it. So that's just another thing of what we talked about before. Surgery reduces the target for inflammation. That's probably how it works mainly. In conclusion, quality of life issues, but health issues, especially if it exacerbates underlying pulmonary disease. Pendulum is shifting towards inflammatory factors. That's where you all come in, balanced approach. So a couple more slides that I thought. So I was in clinic last week and I thought, okay, I'm just going to demonstrate how we do this all the time. So a day in the life, that was the Sergeant Pepper thing. Okay, boomer. So we had a 19-year-old, this is a day in my life in clinic, last week, complaints of, this patient on the thing, it said headache, and they had seen a bunch of other people, so I told the resident, this is going to be trouble. They're going to be probably the usual obsessive, compulsive, angry, chronic headache patient, but actually they were a very smart, pleasant UW student. And her main complaint, number one, was congestion. Number two was postnasal drip. Then it was like, yeah, and I get shooting facial pain and migraine. I know I have migraine. Everybody in my family has migraine. And I stay well hydrated and I get more sleep and I don't text at night and da-da-da-da-da-da. And so her, inevitably, of course, she had no sinusitis on CT and she had tried everything. We said, look, we can do, but she had huge turbinates. We said, we can do a turbinate reduction. Again, it's going to make you breathe better. It's going to reduce the postnasal drip. It might reduce the trigger for facial pain and migraine. And if not, I recommend go to neurology. So that's just kind of a summary of like what we've been talking about. But that was a real, and she was like, fine, let's do it. So, well, we can't because there's fungus and all the ORs are closed. But I can say that because without violating the non-disclosure, because it was on NPR this morning. I did not. There's an I'm missing the emergency meeting. By the way, of all surgeons, required emergency meeting right now. So, and I was talking to somebody, one of my partners, and I go like, "Yeah, I'm going to miss it. It's okay. They can lie to me cheaper by email." Anyway, but so that's that one. I didn't say that.
So migraine is always a touchy subject, at least in adults. I mean, my belief is that people really have vascular migraine. Allergy may make it worse, but it's not an allergic disease.
Correct. It co-associates to a huge degree in kids. So that is a point. Like we said, so it is amazing if the kids that have migraine, the big turbinates, the long pale uvula, the allergic rhinitis symptoms, the postnasal drip, and on and on and on, super, super common association. So you will definitely see that in kids a lot, for sure. And then this is just another one. So this is one of my chronic patients, known cystic fibrosis that said 2 or 3 previous surgeries. The last one was in 2015 for polyps. Now has nasal congestion. This is not him, but this is what we talked about briefly. This is the last slide. This is what polyps might look like. This is the left nasal cavity, inferior turbinate down here, middle turbinate smushed over here somewhere, and then in the middle meatus, pale fleshy gray thing. That's what polyps looks like. So again, I tell the residents, look at a line from nostril up towards the medial canthus, halfway up that line. If it looks like that, that's polyps. But this kid actually didn't look like that. He looked like the big turbinate slide. And, it's very common with CF that by the time they get to 15 or so, whatever, maturation of systemic immunity or something, they don't get polypy anymore, the kids that have polyps. And so refer to allergy clinic first because he had a lot of overall allergy symptoms. So, and actually he was a kid on the Capitor or whatever. He's a kid that's on the new, he had the 15% genetic, like a Delta F508 and some other thing, heterozygous, where that new genetic medicine, he fit that. He's been on for a couple of years, and he's like a normal kid. So he had no polyps, his lungs were fine, athlete, he just has allergies. So that was just, like what we were expecting to see, we didn't see. And of course now with CF, there's the brand new thing that's going to work for the Delta F508 homozygous. So you're going to see CF turn into this chronic disease for most people that they're going to maybe live a normal lifestyle, but they can have allergies just like anybody else. All right, so that was all of that. Any other questions about that? All right, we got done on time. Yes.
How often will you culture people to convince them they're not infectious? Because I've started doing that a lot more since we have an ENT surgeon who will actually help me now. And then you say you're not infected, and a lot of times the people will finally go away and give up on antibiotics. You have to tell them they're not infected.
So we culture a lot, and it's very easy to do. A couple practical tips. You want to, so we take the little swab and we try to hit the middle meatus again, or wherever there's purulent secretions. And then in our lab, we tell a little white lie. We say routine bacteriology and sensitivities, and then we say the culture came from the left maxillary sinus or something. Because if we say nasal, their protocol is they won't do sensitivities. And the most common thing we're going to run into kids is non-typable H flu, but we'll get a profile on what it's resistant to. More and more, they're amoxicillin resistant and so forth. But yeah, I mean, we culture everything because why not? Yeah. But what you will find, I bet, what you're going to find on those non-infected patients, though, you're going to find, not infrequently Staph aureus, like low-growth Staph aureus or coagulase negative Staph aureus. But I think that is a target for mupirocin if they have symptoms. You can always try it and see if they feel better. Can't hurt them. Say, try this for a couple weeks, see what you think. So that's a common thing there. Okay. All right, thank you very much. Yeah.
Who does allergy testing at Children's?
Nobody. It's politically verboten. It's up there with fungus. So we do have, we have a problem with, remember, whatever, like, I don't know, 65% of our patients are Medicaid, and they are challenged to get allergy testing for sure, right? So it's a problem for us, yeah.
Yeah, we know it's a problem.
Yeah.
One more question, Scott.
Yeah.
Greg told us his formula for mupirocin and budesonide to use, and he says that's the best way to treat these people. But he's saying that high volume and low pressure is what he's recommending for irrigation. Do you use volume in kids, or you just put it in there?
So I think there's a couple, kids are a little different I'm glad you brought that up. So number one, they don't tolerate any pressure or anything. So it's just like a little squeeze bottle, squirt. Like, well, if they're super little, we'll say lay them flat or have dad hug, hand back, nose up, squirt, or something like that. The other thing is, my advice is don't use budesonide in kids because they get too much systemic absorption. I've had some older teenagers with aspirin exacerbated respiratory disease polyposis where nothing else works, which is more of an adult thing, and we'll do it for defined periods. But I learned that the hard way by making some kids cushingoid. So that's too much steroids for kids. So I wouldn't do that in kids, with rare exception of like an aspirin polyp kid, a teenager that nothing's working. It works great. I saw somebody recently that was on it and they said like, oh my God, this works great. I go like, yeah, but you can't keep doing that because there's too much absorption. Yeah.
You have a pharmacy, don't you, that compounds budesonide
Yeah,
and
we have a couple of
mupirocin?
them do. And then, they don't compound the two together. They just give you the two things and then they make you mix them yourself. But yeah, we can do that. And Greg has a formula over on Polsbo or something that he uses.
Right. I think that's more of an adult thing, but you have a little problem with kids.
So you don't have them do it any special way to irrigate. You just have parents shoot it up their nose without pulmocord. Or mupirocin solution up their nose.
You'll get the occasional person who's really, really into the neti pot or something, great. But the majority of times we have a compliance problem for parents. And here's a comment. I just had this talk. So like, let's say, like I'm at my wit's end and Billy is driving me crazy and blah, 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 blah. And I'll go like, well, okay, we're going to try this. And I'll go like, well, the spray routine. I'll go like, oh no, there's no way. And I go like, really? I go like in my world, a very common scenario would be somebody has cystic fibrosis or terrible asthma. And I tell the parents, if they do this nose spray, that could significantly reduce the likelihood of getting up in the middle of the night and running to the emergency room. They look at me and they go like, done. Thank you, doctor. right? So it all depends on your perspective, right? So usually, sometimes that works with them, but yeah, it's very doable. But we have to find something that's kind of practical for kids, because they're kids. And it seems to work pretty well. I don't know how to eject this.
Don't worry about it.
It's a
Thank
bad
you very
noise.
much.
All right, thank you.
All right. Maybe next year you'll have an allergy clinic at children.
And now some retired guys can grow their staff at
He could then go like 4 baby. You guys already have